Hi, I'm Elmi Mueller. I am a transplant surgeon in Cape Town, and I'm also the president of the Transplantation Society. I've been asked a few questions by Kavita Vishwakarma, who wanted me to do something personal and give a little bit of a personal perspective on some of the work I do, and probably also on the talk that you will receive from me and which is going to be delivered on the 5th of August. So the first question she asked me was what challenges I encountered when I performed the first HIV transplant. So that is a long story, but the first HIV transplant was performed in 2008. I started working on this project in about 2006 when I realized that HIV positive patients have no options in South Africa. The fact that they had no treatment available to them. They were not qualifying for dialysis. They were not transplant candidates. And they were generally young, economically active patients who had their whole life ahead of them. And they also had very little other confounding medical diseases. So I felt that this is really a shame that we are losing these patients. And I felt very determined to do something for them. But it was a difficult time in South Africa. We only got antiretroviral therapy available in the country in 2004. There was a lot of HIV denialism in the political landscape. Mbeki, who was the president between 2001 and 2006, were HIV denialist, and he did not believe the virus exists. So there was no plan from the political side to treat these patients. And when antiretroviral therapy became available, generally medical doctors were quite worried about how these patients will perform, how they will fit into the health system, and people were nervous. There were also surgeons who were nervous about working on HIV positive recipients, and who didn't feel comfortable to do operations on these patients. So I was met with quite a bit of resistance when I started the program, and a lot of people felt that I'm opening a can of worms. These patients will overwhelm the system, or we could possibly transplant them, and then they might become very, very ill, fill our hospital beds, and take away opportunities from HIV negative patients. So yes, it was a very difficult time. It needed a lot of meetings and a lot of discussion. And only after about 2 years did I really get the full permission to continue the program. I was very privileged from the point of view that the first few patients did really well. So when I started the program in 2008, the first 4 patients just absolutely did fantastic. And one of them was a woman of about 24, had a small kid. And she was an amazing person in this group who could speak and who could show how wonderful she did. And of course, there was this emotional appeal with her young kids. So the program really officially was endorsed about 2 years later. And then it took quite a bit of time to get dialysis policies changed so that HIV patients also could get dialysis, but that changed about another 2 years later. So at least things got better. So Kavita asked me how the scenario changed for HIV positive renal patients over the last decade in terms of overall care and availability of transplant. And that, I'm happy to say, is a good news story. HIV has become much more, I would say, common in terms of treatment options. We have loads of drugs now available in South Africa and in other parts of the world. It's even more. Doctors are much more used to it, so they are not as scared as what they were in the beginning. Patients are more comfortable to speak about their HIV status. And that's important from a public perspective. And we also know that the patients do well. It's a chronic disease that we can control. It's a chronic disease without major long-term complications if it's correctly treated. So today, HIV patients compete for dialysis and transplantation programs similarly to HIV negative programs. So I think the situation has become much, much better in the South African context. And internationally, I also believe that patients with HIV have many more opportunities to receive transplants and dialysis than what they had 10, 15 years ago. Now, Kavita asked me to comment on what India can learn from the equitable organ donation allocation system that I created in Africa. Now, I first need to say it's not quite me, but what we did is we had loads of meetings with stakeholders, discussions. And when I was the president of the South African Transplant Society, that was one of my main objectives, to get equitable allocation done, to get people to share a common waiting list. Just like India, we have state and private patients. And what we did not want to do is to set up a program that would benefit patients who have private medical insurance. So we did not want to have a program where the patients with money could easier access a renal transplant. And therefore, what we agreed in the Western Cape was to have a common shared waiting list with patients from the state and from the private sector on that waiting list. And that makes allocation fairly equitable in terms of when a kidney gets allocated, it gets allocated to the patient on the top of the list, not allocated to whether the patient has got insurance. And that is, I think, an important thing that we managed to do. But what can India learn? I think we probably must learn more from India than what India can learn from us. But in general, I think what I would say is that there isn't a plan that fits everybody. And that is true for people in Europe, true for people in the USA, and true for us in the low and middle income countries. We have to work out plans and practical ways forward that work in our setting. And in many of these high-income countries, they have expensive organ procurement organizations that charge per organ, that is very well resourced, and of course make availability and structuring programs much easier, but it also comes with a price tag. And we haven't gone that route in South Africa. We are not really able to do that cost effectively, especially for our state patients. So we haven't done that, but we work as a team through different hospitals in one setting, and we share the responsibility of harvesting the deceased donors and then utilizing the kidney on a common waiting list. So I think what I would say, if you ask me what can you learn, is just to say one size doesn't fit all. And it's important that you discuss in your local environment what is your best way for you, knowing your limitations and knowing your setting and thinking about your ethical conditions, which is probably closer to ours than the high-income countries. You ask me, Kavita, what is my practical tips for middle and low-income countries that struggle with resources? I have some reservation about the fact that dialysis is always the first modality of choice for renal replacement therapy. I believe that dialysis is a good option, but I'm not sure dialysis should always be the first option. And the truth is we compete from the transplant point of view with some of the biggest economic industries in the world. And these industries can advertise, they can make their resource available, they can reach out to political stakeholders, they can make sure that dialysis is on the table for hospitals and patients. And often the cost of putting up these programs are not that much less than putting up a transplant program. So I believe that countries who have an opportunity to rather set up a primary transplant program with a dialysis backup program will make very good progress. And that is something that a lot of the lower middle income countries in Africa needs to consider. Instead of setting up more dialysis units, do we not need dialysis only as a backup for a transplant unit? Of course, transplantation needs a lot of infrastructure, human resources, expertise, but I believe it's possible to get some of those things done, especially if we're going to recalculate the costs from dialysis to transplantation and shift those money and those incomes back into the transplant field. So I believe that would be an important thing. I think transplantation needs to be driven from the top down and from the bottom up as well. So politicians and ministers of health need to give us their buy-in to drive transplant programs, and we definitely need that. We need organizations like the WHO, like TTS, to help us with that. But we can also, as clinicians on the ground, drive things for our patients. And we have the knowledge and the expertise to do that in our own geographical settings, and we should do that. But the last thing I want to say about that is that we mustn't forget about the patient's voice, because we often as doctors think we must do it and we have to be the patient's advocate. And yes, that's true. But many patients are very strong advocates for their own health and well-being, and they are actually our partners in this. And I think one of the things we need to do when we want to drive these programs and set up these programs is to use our patients to help us to do that. And the last question Kavita sent me was, how do you create work-life balance with all that you do? Kavita, that's a loaded question. One can never be completely balanced, and I think there's sometimes when you prioritize your work, and there's sometimes when you prioritize your family, and hopefully these two things will not interact too badly with each other, so that you can manage these different aspects of your life together. It's difficult sometimes. It is about saying no to some things, and sometimes we have to say no to things at work and prioritize our families, and sometimes we have to say no to our families and prioritize our work. And I don't know if there's anybody who can say they always get that right, but I believe that if you have good communication with your family, if you know what their needs and wants are, and you consider that as part of your planning of your day-to-day job and work, that you can be able to meet their needs. At work, usually I try to be quite focused on my work and not to worry too much about my family. I am very privileged that my husband had a very hands-on approach with my kids, and when I could not be at home or do things with the kids, he was usually around. So that gives me a lot of reassurance. Nowadays my kids are big and they are students, so they don't need me that much anymore, and they don't really want me. So it becomes easier as they get older. But I think it's also about trying to be present wherever you are. So if you are at home, to be present at home, to be able to put the work aside and do what you need to do at home. And then also the same at work, to be present at work and to make sure you have an infrastructure and support structure for your children at home, if you have children. And then it's important to look after yourself. It is important to be able to say, I need time off, or I need a break, or I'm not going to do something because I'm not able to, it's too much. I think as medical practitioners, we tend to always prioritize our patients. It's the culture in our business to prioritize the needs of other people. But today, with mental health and mental well-being so much on the cards and so much discussed, it is very important for us as healthcare practitioners to also look after ourselves. So I believe that everybody should do that. And if you need to sometimes say no to something at work, that is part of that process. So Kavita, thanks for sending me these questions. I hope you will have a wonderful conference, and I'm looking forward to hear some of the talks that will be presented on the platform. Thank you.